All right, everybody. This is going to be the rest of chapter 5. I'm going to go into a share screen because it doesn't let me do this beforehand. So I think that it's working. All right, so if I slideshow it, play from current slide. Okay, here we go. So I want to finish this chapter. Please bear with me. 7:20 and I've worked all day. But I figure if I do this, we'll have class. And if I don't do this, we absolutely won't have class. And then I'll need to do it in a rush. So here we go. We talked a little bit about the shoulder itself based on its structure being frequently injured. Hold on, guys. I'm just making sure this is actually recording because now I'm nervous. It says it's paused. Why is it paused? It should not be paused. There should be no pause. Stop the share. We're recording. Let's try this one more time. All right, so if we talk specifically about the rotator cuff, we're talking about 4 muscles, right? Your subscap is going to be on the anterior aspect of your scapula, where your supraspinatus, infraspinatus, and teres minor are going to go superior to inferior on the posterior scapula. Okay. All of them come together and attach on the humeral head. The way that they insert allows for humeral rotation. As we raise up the arm, we need that humeral head to stay in the middle of that glenoid fossa. So these muscles are not huge in nature. They're not your power muscles, but they are absolutely important to maintain that humeral head with a glenoid elevation, okay? So I always tell patients when we talk about these, it's like legs on a coffee table. You kick out one, bad things happen as you try and elevate it because it's wobbly. And that's kind of the same concept. Something else I want to talk about is GERD, glenohumeral internal rotation deficit. All right, you'll see this a lot in the literature, really applies to overhead throwing athletes. You measure internal rotation on your dominant side, your throwing side versus your non-dominant side. If we have more than a 20% difference, those athletes are going to be at a much higher risk for injury. So GERD is really going to be something that we need to stabilize and improve so that we decrease that injury likelihood. And it will also allow for an improvement in performance. So just recognize we're going to see that come up. We talked at length about that scapulothoracic joint and how it and your clavicle, your AC and your SC joint have to work together with this glenohumeral joint, right? So all 4 of them are together. This pictorial really gives you what happens at the shoulder joint. If we see the big motion of abduction, the shoulder girdle, your scapulothoracic joint is going to have to upwardly rotate. If we flex, it's going to have to elevate and upwardly rotate to allow the shoulder motion of flexion to occur, okay? So this just really is a nice pictorial that reminds you of what you need to see. So if we internally rotate, it is going to abduct your scapula. So by the same token, if you externally rotate, you're going to adduct or retract your scapula. So make sure that you understand what happens complementary between these 2 joints for the big motion that you would expect to see at the shoulder. Here's just another breakdown. If we took abduction, we talked about it's almost a 2-for-1. So 60 degrees of scapular upward rotation had to happen, 25 degrees of scapular elevation, and then we're going to see 95 to maybe 110 degrees of glenohumeral abduction occur. Okay, it's not necessarily you have to see 10 degrees of this to see 5 degrees here, and another 8 degrees results in 5 degrees. It's synergistic. It happens in fluidity, but it all has to happen together. So again, that generally accepted ratio 2-to-1. Every individual is going to be different. Poor posture is going to have a relationship there. So all of these things will be together. This video is just a really nice way of looking at abduction. It's that upward lateral movement of the humerus out to the side, away from the body. Adduction is going to come across in front. You know, we really want that adduction to occur in a straight plane. I'm going to point out, depending on the bulk of the individual, it might be harder to get your arms out in front. So if you have a guy who's been to the gym and is really broad and very muscle bound, they may not have much adduction, right? They kind of stand with their arms out to the side as it is and can't get them down. Keep that in mind. The other thing, if you have a very well-endowed female, you can't necessarily break that plane because their chest is in the way. So just kind of keep that in mind that there'll be some differences in normal. This is just looking at flexion and extension, all right? So if we talk about the shoulder, these are the motions that we would assume. So one of your nuggets, so grab a little piece of paper, scribble down next to yourself. You want to send me, I'm gonna do these nuggets as we go because it's our participation, and you know, 3 points if you send me the email that you're going to. Flexion of the shoulder happens in which plane, around which axis. So the email you send me is going to have number 1, flexion of the shoulder. You're going to tell me what plane it's happening in, about which axis, okay? So there is your first 2 points. These are free points, by the way, so do it. Extension is going to be that posterior humerus movement, straight plane. So here is your glenohumeral horizontal AB and adduction, right? So adduction is going to cross midline. Abduction is going to be that transverse extension away, okay? Internal rotation, external rotation. When we look at true external rotation, people are going to look to try and get more motion. So if you look at that top example, as she's moving into external rotation, we call this the money. If you were to tuck a $20 bill and pin it between your elbow and your thorax, and you can externally rotate, if you drop the $20 bill, it is mine, okay? That way you don't see people cheating and trying to do this combination and add in some abduction. This with that elbow pinned will give you true external rotation. Our diagonal abduction is going to be movement of that humerus away from the midline of the body, and clearly adduction is going to come back down, okay, across the midline of the body. Again, you take something like this, and if you have an incredibly well-endowed female, you are not going to really be able to necessarily manage that because of mass. So keep that in mind. Muscles. If we're talking about anything intrinsic to the glenohumeral joint, those muscles are going to have to originate on the scapular clavicle. So we're going to see that being our deltoid, our coracobrachialis, our teres major, and your rotator cuff group. I need you to know the 4 muscles of the rotator cuff, okay? It is a cuff, not a cup. Oh, don't make me lose my mind. But you need to know those 4 exist, okay? They're a pair, and you have to understand that you can't necessarily break down and talk about one without the others. Extrinsic to the GH joint are going to be your lats and your pec major, okay? So recognize which is intrinsic to the glenohumeral and which is extrinsic. So anteriorly, we have our pec major. I don't know if you can see my pointer as it goes. I don't know whether it stays here. But remember, this is going to be your pec major. And when we took it off, this little guy here is your pec minor. Okay. Your coracobrachialis is going to be in here. Okay. Underneath this big muscle that's your deltoid. Okay. When we look anteriorly again, but on the other side of your scapula is going to be your subscap. So none of these pictures are really, well, your subscap is over here. You just have to recognize that the rest of your body has been removed, okay? So on that front anterior aspect of the scapula is where that's gonna sit. And when we look at this view, your supraspinatus is gonna be right at the top, and it is not pictured here, easily seen. You kind of have to pull that delta off because here's going to be your upper trap. So we know that the deltoid is here and large. If we pull that deltoid muscle off, here is going to be that supraspinatus that sits right up here. I'm going to tell you that the top right picture is a great picture. I could see that as being a fantastic quiz picture where we can label everything. Could you just not see that as being fantastic? Because I can see it as being truly fantastical. So I put a big fat star next to that and make sure that you know what they are. Okay. You've got here your big lat muscle. You have your little lat. Which follows the same thing, has the same actions. And then you can see that infraspinatus and your teres minor, okay? So recognize what you can see and from where. This is gonna be a view where you've got somebody laying supine and you cut their arm off above their elbow, all right? So as you look up, you can kind of see that deltoid sit on that lateral aspect. You can see your biceps here on the front, triceps on the back component. You can see where that lat and that teres minor kind of come through that armpit to their attachment sites, okay? They're pretty big and interesting to kind of see how they're all related together. So just a different view of that armpit. This is a reminder of what muscles are innervated by what. So as you go ahead and write your flashcards, this should be a way to go back and add it. The slides got a little chaotic when I tried to add them on, but recognize your pec major has two nerves, your lateral pectoral nerve, C5 to 7, and your medial pectoral nerve, C8 to T1. Okay, so make sure you're going back and you're translating those onto the slides that you need to memorize, okay? Our deltoid has the axillary nerve. That's going to be C5-6 in parentheses. That also innervates your teres minor. And some sensation to the lateral skin over that deltoid. Okay. So I just need you to make sure we're learning these, right? And then we'll go back through and pop them in where they need to be. Your deltoid, right? Huge muscle group, right? Origin is going to be the anterior lateral third of the clavicle, the acromion, and the inferior edge of the spine of the scapula. Okay, so there's going to be its origins. It inserts on that deltoid tuberosity on the lateral humerus. Remember when we talked about where your deltoid was and we came down, we found that tender spot? That's going to be that deltoid insertion, okay? It is responsible, it's kind of like the trap, divided into 3 parts. If it's on the anterior, it is going to be responsible for flexion, horizontal adduction, some diagonal adduction, and internal rotation. All of the fibers will help with abduction because they generally are going to work together. Our posterior fibers are going to really be responsible for extension, horizontal abduction, diagonal abduction, and external rotation. Those middle fibers are only going to be responsible for abduction, greatly assisted by that anterior and posterior. Remember, we talked about those synergistic in nature, okay? The two of them working together, even though one flexes and one extends, is going to meet in the middle to help with abduction. So your deltoid is responsible as the prime mover of abduction. When we look at the pec major, okay, again, it's going to originate on that medial half surface of the clavicle, the anterior surface of the costal cartilage of ribs 1 through 6, and that next to adjoining portion of the sternum, okay? They insert through a flat tendon 2 to 3 inches wide on the lateral lip of the intertubercular groove of the humerus. So over here on the edge of that humerus, on that lip, is where that slip is going to come in. And it's going to be a pretty wide, flat band for the insertion of that pec major, okay? So it has actions, a lot of them, because the way that those fibers are oriented, you can see how they all are at different diagonal. So our upper fibers, the clavicular head, what primarily comes off the clavicle, it internally rotates, horizontal adduction, okay? It will help abduct once we get up to 90 degrees, okay? And it will help with adduction if we're below 90 degrees. So again, one of those muscles that does everything. The lower fibers, because of where it attaches on that humerus, are responsible for internal rotation, horizontal adduction, diagonal adduction, and it will help bring us back to extension from a flexed and adducted position. Okay, so again, it does a ton of things, but again, all based on fibroline. Our lats. They originate in the posterior crest of the ilium, the back of the sacrum, the spinous processes of all of the lumbar and the lower thoracic vertebrae. So T6 to L5, and then from the posterior aspect of the ilium and the sacrum, okay? Also gonna come off the slips of those last 3 ribs. So huge complex that is our lats. Okay, they're gonna go up and they're going to insert on the medial lip of the intertubercular groove of the humerus. So when you think about it, that's why you can see it come through that armpit, wraps around to that medial. Because it comes to the inside, but starts on the back, think about when it shortens, it's going to internally rotate, okay? So it is responsible for adduction, extension, internal rotation, and horizontal abduction, okay? So by nature of where it is in fiber alignment, that is what it is powerful for, okay? So think about machine-wise, it is going to be your lat pull down, okay? It's a huge muscle. If you think about all of its actions, it is responsible for a pull-up. If we close chain it, if we fix our arms and we go through all of those same motions, that's what's going to allow us the ability to do a pull-up, okay? Your teres major muscle. It is going to originate on the inferior third of the lateral border of the scapula, also inserting at the medial lip of the intertubercular groove. It is responsible for extension, okay, particularly from a flexed position, internal rotation, and adduction. Okay. So again, this is usually labeled as the little lat. It will have the same functionality because of that attachment on that medial lip of the intertubercular groove and its orientation coming off the scapula, okay? So keep in mind, it's going to help internally rotate that humerus. Our coracobrachialis is not a huge muscle. It originates, wait for it, on the coracoid, and it inserts on the middle of the medial aspect of the humeral shaft. So its responsibility is flexion Because you can see how it's offset medially, it can also help with adduction, horizontal adduction, and some diagonal adduction. So all you have to know is it flexes and adducts. Talked about your rotator cuff, okay? This view straight down really helps you orient to your supraspinatus, that infraspinatus below, and that subscap on this anterior aspect, okay? So let's look at how it attaches. They all attach at the tubercles, okay? So your supraspinatus attaches at the greater tubercle. On the top, right underneath it, is going to be your infraspinatus. And then underneath that is also going to be your teres minor, okay? Because of how they attach, it really functions in how it works. Because the infraspinatus and the teres minor are a posterior greater tubercle attachment, they will externally rotate. They're on the back. So they start on the back, they end on the back. If they shorten, they're going to pull you into external rotation. Your subscap, because it attaches to the lesser tubercle and travels anterior, it will be internal rotation. Okay. So supraspinatus is going to abduct. Our infra and our teres minor are going to be our external rotators. Our subscap is going to be our internal rotators. You can see how all of those things working together are going to give us where they are. Your rotator cuff muscles are not big, okay? They have to have some strength, but they also have to have endurance to task. When we do repetitious things, overhead tasks, throwing, swimming, pitching, we work overhead. We're doing a lot of this. We can have poor technique, muscle fatigue. We can really put ourselves in a position where we have a failure of the rotator cuff. Okay, they must stabilize. I can't tell you how many folks I've seen over the years where they were okay, and then it failed when they went to pick up a gallon of milk out of the refrigerator. The gallon of milk didn't do it. It was the 10 years beating it up into that point that did it. You'll often see impingement within the acromial space. So we talked a lot about posture. So if we look at things and we're slumped, all right? So we've taken the space that should be in that glenoid and your humeral head, and all of a sudden we've smushed it. Every time we raise up, we're catching and banging those soft tissues, those rotator cuff insertion points on a bony backdrop. Soft tissue and bone never works out. Soft tissue will always fail, okay? So that's where we see our tendinitises, our tendinoses, our bursitis, our rotator cuff impingements. It's because soft tissue was not meant to beat bone, okay? Talk a little bit about our subscap. It is our internally rotator, okay? So it originates on the entire anterior surface of the scapula in that subscapular fossa. It attaches at that lesser tubercle, okay? So because of that, it is an internal rotator, an adductor, an extensor. And again, as with all of the rotator cuff muscles, it is a stabilizer of the humeral head, okay? So it is the anterior aspect. If we look at this, there's no real great way to put your fingertips on it, okay? So to do a direct mobilization and to work on that muscle, you kind of have to go through the armpit and reach over and work on it. It is not comfortable, okay? Supraspinatus originates in the medial 2/3 of the supraspinatus fossa, inserts superiorly at the top of the greater tubercle. It is our abductor, and again, our stabilizer of the humeral head and the glenoid fossa. That will show up on every single rotator cuff muscle. Don't forget it. Our infra is going to originate in the posterior surface of the scapula below the spine, okay? Inserts again in that greater tubercle on the back side of it, posterior aspect. External rotator, a horizontal abductor, an extensor, and imagine that, a stabilizer, okay? Teres minor. It is going to come off that posterior scapula lateral border. It's going to insert greater tubercle, posterior side. So it's an external rotator, a horizontal abductor, an extender, and a stabilizer, okay? So our infraspinatus and our teres minor really have the same actions, just come off different points of it. Okay. What works together? Our anterior delt and our upper pec are going to work together to flex your arm. If we're looking at extension, we have to have things that come off the back, our teres major, our lats, and our lower pec major. Remember, fiber alignment is going to be what does that. Those are going to be what works together for shoulder extension. Glenohumeral abduction, your delt, hugely responsible. Your supraspinatus, not hugely strong, but absolutely necessary. One of the tests that we do is called an empty can. You raise your arm out and you turn your thumb over. Okay, we take a lot of the deltoid out. If you can't maintain that arm being held up and your arm drops down, you can feel pretty secure that we have a big issue with our supraspinatus. Because of the nature and the bony alignment in which it attaches, it is usually the first one torn, okay? Oftentimes we'll have two tears of the rotator cuff muscles. Usually you'll wipe out supraspinatus and then you'll get into the infraspinatus. Generally speaking, you will not tear the teres minor without having done the supraspinatus and infraspinatus before it, okay? So it's like kind of cutting straight down, kind of take them out in the order in which they appear, okay? Also bear in mind that glenohumeral abduction will be assisted by the upper pec major because of the fiber alignment, okay? Abduction, lat pull, so we can do our lat pull downs. And we remember that our lats are supported by teres major and the lower pec, okay? So again, the pictures of what works together. Internal rotation, lats, teres major, subscap, pec major, okay? They all attach front medial of the humerus. And we see how as long as it comes across and attaches there, is going to be an internal rotator. External rotator, infraspinatus, teres minor. Okay? They have to have a posterior attachment to allow that rotation to occur. Horizontal abduction, posterior delt, our middle delt, our infraspinatus, and our teres minor are really going to be what allows for that to happen. Because again, it has to be middle to the back, right? I'm not going to read all of these to you. This is just a different way to group them, okay? So you think about when you learn them as where they originate, where they attach. Now we have to look at it and see in terms of what works together in synergy. How do these things work and move? So when we look at diagonal abduction, we're going to have things that work low and things that work high, okay? So just again, recognize that as we move, where we are is different than where we started. So every time we do that, the fibers are going to change. Am I going to be this picky for you? No. I just want you to understand how it has to work together to occur. I hope that makes sense. Remember, I gave you the first thing you were going to do for me in it. So the second question, and this is all in one email, by the way, is going to be to remind me what your rotator cuff muscles are. Okay. And then I want to know which of them is an internal rotator. So I want you to star that muscle. Okay. So those are going to be the things that you give me, and they will be bonus points. So they will end up showing up on at the end. I'll probably just have a running total and I'll just start adding points in. So this needs to be received by Saturday. No, before class on Monday. So if I don't have the, if I don't have the email before we walk in Monday, it's gonna be the problem. I'm choking, I'm sorry. Because I did these. I'm going to go back through and put a chapter 4 quiz on the computer. It will be open until class on Monday. I want you to take it. It'll be a 10-question multiple choice true false. I would not think that that'll be the only thing you see, but that will be the chapter 4 will be on there. Okay, so send me an email. You get 3 bonus points that some of you will like for your test, and that'll give us an idea where we are. All right. If you're seeing this, hope you had a great snow day. If you're not seeing it, then it's all a moot point. All right, I'll talk to you guys later. If you need me, please email.